Hi, I'm George Perry, and we're going to look at Dental Implants A to Z Section 7, which is really our final section, and it really is going to take everything we've been studying and learning over the last 6 sections and put them together, because we're going to deal with the aesthetic edentulous management of the patient. When we have a patient that loses all their teeth, this is a traumatic psychological problem for the patient, but it's also a technical challenge for the restorative dentist. You know, the oversimplification of this treatment, well, we're going to stick in a couple implants and we're going to put on some sort of attachment and make overdentures, really has led to all sorts of problems and dissatisfaction with the patient. We also need to understand that there are differences for these patients. There's differences between the edentulous maxilla and the mandible. So why would we think about doing implants in the edentulous maxilla? To improve retention, to decrease palatal coverage, to give a fixed result. Do we always want a fixed result? Preserve bone, of course, but does it give lip support? Does it give aesthetics? And the answer has to be no. So understanding why implants are used are important, and then what the ultimate goals are. You know, there's subtle things that we need to think about. When we're doing an overlay or an overdenture, do we want to use a bar? Do we want to use individual attachments? Even if we're using a bar, do we need to consider stresses? Do we need to consider the forces of occlusion? Do we need to build in stress relief? Do we need to think about axis of rotation? All those factors are important to consider, whether we decide to use it or not. So how we manage force may be the issue with an overdenture. It's also maybe surprising to mention that the most aesthetic restoration in the moderate to severely resorbed maxilla is a denture. Being able to place implants underneath that gives the functionality that we're trying to achieve may be the key to the whole treatment. If we use individual attachments, is that the bottom line? And I think this is an area that we need to look at because it's been oversimplified, and it just makes it sound like, oh yeah, you stick in some implants and we can do an overdenture based on individual attachments. And there's issues we need to look at to really get the result that we want to see. I think another way to look at this is from the fixed versus removable point of view, and it's really a cost issue. There's an assumption that anything removable must be cheaper than fixed, and that's not the case. Especially if you're doing a hybrid type fixed restoration, the cost for an overdenture could be the same or even more. So don't assume that the overdenture is always cheaper, and that's not the way we want to sell the case to the patient. Another way to look at this is it easier and more predictable to do screw retained or cemented? From my previous lectures, I think it's clear that it sometimes is easier and more predictable to do a screw retained as opposed to a cemented restoration, even though that's the common feeling. Oh, I don't really know what I'm doing, I'm going to do a cemented restoration. And then I see all the problems that come from that. We've also discussed a lot, and I feel so strongly about this, about that we need a way to make an effective and reliable final impression in a reasonable, efficient way, and we can do that. There is no question that I can generate a master model that will give me exactly the functionality on my laboratory bench as I have in the mouth. There are different types of treatments, and we need to review these. A conventional denture versus an overdenture, and the overdenture can be completely supported by the implants or just assisted by the implants. And then fixed. Do we do porcelain fused to metal, or do we do a hybrid, a fixed bone anchored bridge? What's so important to understand is the challenges of doing the fixed. If we don't have enough restorative space and we've quoted a fee for a fixed bone anchored bridge, we could be killed because the costs, our laboratory costs for doing the porcelain fused to metal might be more than what we've quoted the patient to do the hybrid restoration. We need to understand the differences of the maxilla versus the mandible. What works wonderfully in the maxilla does not work that well in the mandible. There's different limitations, there's different physiological challenges. And we're not just talking about the quantity and quality of bone, the shapes, the clearances. These are all technical issues. We're talking really about how the patient will appreciate the treatment. I think it's also important to understand all these restorations require a different technical amount of restorative space. So how we communicate the surgeon where the head of the implant is depends on what our final restoration might be. The amount of clearance, the amount of bone reduction, which just sounds horrible, that we have to take away bone on many cases, but we may need to have restorative space. Phonetics, Do we always need space like this? Of course not. But even in a closed down hybrid in the maxilla, we can have problems with airflow, saliva control. We need to know how to talk to the patient about these so that they will understand what the limitations are. When we put all this together, I think we can do a good job in treatment planning the cases effectively, educating the patient, and getting the outcome we want to have.
For more education programs, visit the Guide Institute at www.guidedental.com.